Hey everybody, welcome back to the ECG channel. My name is Reed, and today we're going to be talking about the precordial leads. In this lecture, the precordial leads are leads V1 through V6. Now, if you haven't, I would go ahead and go to the previous video in this lecture series in the ECG playlist here where we talk about the limb leads so that you can get a little bit of a background on those first, and then we're going to build upon that and talk about a little bit why and how these work, how they're created and how they work. And so remember that a lead, I'm just going to zoom in on this kind of white space here. What is a lead, right? Well, a lead is is created by two different electrodes, right? So you have some recording device here, right? Here's my recording device. And so I'll call it device right there, the ECG machine, right? This is my ECG machine. And this machine has a recording electrode, two of them, that are located like so. And they measure the change in electrical activity that occurs between them along this axis specifically, right? And so the machine, what it does is it will kind of artificially in its mind, it will label one of them as a negative side and one of them as a positive side, or a negative electrode and a positive electrode, right? And so any time you get positive signals heading from the negative side to the positive side along this axis, you're going to get a deflection on an ECG rhythm that is positive, right? And on the other end of the spectrum, if you have a wave of depolarization or positive forces that are going in the direction from positive to the negative electrode along that axis, is really important, along that axis, then you will get a negative deflection, right? The amplitude of these deflections, which means the height of these deflections, depends on the total amount of positive forces, right? So from a cardiac standpoint, like how many heart cells, right? The density, as well as how well it aligns with that force. Now also remember that if you have positive forces that are moving perpendicular to the lead that's created, you'll get what we call something that is isoelectric, right? In other words, it is equally positive and negative because it is not going more toward or away from either of the electrode, right? So that will be more of a perpendicular waveform. And so we know that the 12 lead ECG has 12 of these leads that are created, right? And so a lead is created between a positive and negative electrode. And the precordial leads are a unique set of 6 leads, okay? And so let's talk a little bit about those. First, we're going to talk about where the electrodes are placed on the chest wall for the precordial leads, right? You'll notice that the precordial leads are measuring forces on a transverse plane, okay? And a transverse plane means kind of a slice through the body horizontally, right? Let's talk a little bit about what I mean, and this will make sense. So I'm going to zoom in on this guy right here. This is my human, okay? And so we have 6 leads. We have 6 electrodes, right? Remember, this is the right side, and this is the left side if we're talking about anatomical positioning, okay? And so what we'll notice is the first lead, V1, that electrode is placed in the 4th intercostal space. So intercostal space meaning between ribs. It's the 4th one down, and it's on the right side of the sternal border. So somewhere about right there is V1, okay? 4th intercostal space, right side of the sternal border. Now the next lead is going to be created with the next electrode placed. This is going to be V2, and that is also on the 4th intercostal space, but this time on the left side of the sternal border, okay? And then you'll notice that we have the next one that you usually would place is going to be, interestingly enough, V4. You actually go down to the 5th intercostal space, but you do midclavicular line. So V4 would be 5th intercostal space. Midclavicular line is V4, right? The clavicle is right here, so like the midclavicular line goes down, right? So 5th intercostal space, midclavicular line. If you go in between those, that's where you get V3 in between those. And then you'll see we have V6 is in the 5th intercostal space, mid-axillary line, and then you have V5 that's in between V6 and V4, right? So that's V5, okay? Notice these are along the chest wall, spreading from the right side through to the axilla, the axillary region on the left side, V6, right? And remember that the heart kind of sits, in this area, right, on the left side. Okay, so that's why they're all concentrated more on the left side. And so, remember that we said that in order to create a lead, we need a positive electrode and we need a negative electrode to do that, okay? Now, all of these V lead electrodes are going to be the positive electrode. And we're going to talk about where's the negative electrode. So imagine I take my transverse cut of this gentleman, right? I take a cut, right? This is my cut here, right? I take a slice through the chest wall in that plane, right? Horizontal. I slice it. This is the diagram I'm going to have that's going to result from that, right? So that's a horizontal cut through this gentleman. We have the right side is here. The left side is here. Posteriorly, this is posterior. This is the posterior wall. Notice that we've got here in our diagram, we've got the vertebral body, right? We know that our vertebral column is on the posterior part of our back, right? So if we slice through it, we would probably slice through a vertebral body. And then anteriorly, right? This is the anterior part of the chest wall. We've got our sternum, right? Which makes sense, right? Our sternum, our chest bone. And so we have our V leads, the stickers, right? We have V1 on that right sternal border, V2 on the left sternal border, and then we progress V3, V4, V5, and V6 all the way to that axillary line, right? This is kind of far lateral side where V6 is. So this is kind of how those leads sit in regards to the chest wall, and this is my cardiac kind of silhouette here that we get within chest wall itself. This is how the heart sits. The heart sits here where the right ventricle, we have our right atria, we have our left atria and left ventricle, right? And notice the heart is not perfectly sitting straight forward to us. It's actually a little bit diagonal, right? And that's just how it sits. And so these leads, we said, the V leads, V1 through V6, these are all of our positive electrodes in our lead system, right? And now we need to define the negative electrode for each of these leads that creates the lead. Well, what's really interesting is that there is not a physical negative electrode, like a sticker, right? These are all stickers. We're putting them on someone's chest. There's actually not a physical sticker for the negative electrode, but what's actually interesting is that the ECG machine is able to calculate a theoretical position for that negative electrode. It's fascinating. It's probably beyond the scope to talk about how they do this in this lecture. But essentially, what you can imagine, the takeaway, is that the negative electrode that is created, I'll draw it in green, it finds a way to place that negative electrode almost like centrally in the chest wall. So this is my big negative electrode, okay? So the negative electrode kind of sits in the chest wall, and so now that single negative electrode is the sole negative electrode that correlates to all of these precordial leads. And so if we draw the lead that is created with each of these, V1 is measuring forces going from that negative electrode to V1, V2 in this orientation, V3 from that negative electrode. We're starting to get more on the anterior portion of the chest wall, V4, and then we get more of the lateral leads, V5 and V6, okay? And so that is how we get the creation of our precordial leads, right? Here is our positive and here is our negative. And so that is how we measure. So we measure, these leads are all measuring forces that are going in those directions, okay? So it's a pretty neat system. And so now that we've defined how these leads are created, let's talk a little bit about, based on the orientation of those leads, what we can expect from a waveform perspective in these leads, right? I think it's just helpful to grasp this concept if we can go through, if it's sinus rhythm, if we have a sinus beat, what should we expect in these leads? So we'll take off the arrows, right? We'll take off these arrows and we'll go from there, okay? So we know the normal cardiac conduction. Normal cardiac conduction begins at my SA node, which is high in the right atrium, right? This is my SA node. And so SA nodes fire off and depolarize the atria, right? It creates a wave of depolarization through the atria. And that wave of depolarization we know creates a P wave, okay? In my P wave, this is where it's kind of fun how the P wave is displayed. We really only care about the P wave, to be honest, in lead V1. It's got the most distinct P wave morphology, and let's talk about why. So if I zoom in, so we have something called the cardiac silhouette, where it's this connective tissue, right, that kind of outlines our heart so that signal gets contained in certain areas. And so actually what happens is the right atria receives the first bout of signal from the SA nodes. The SA node fires off, and the right atria is the first part of our atria to fire off, and we get depolarization of the right atria first. And so notice that the right atria, it's kind of pointed, this depolarization wave is kind of pointed towards V1. So that first initial part of the P wave in V1 is going to be positive, right? Because if it's going towards V1, it's going to be positive, right? Forces are going towards that positive electrode. And then there's something really interesting. There's this little bundle of cells in between the atria, that's my little bundle of cells called Bachmann's bundle, that allows for that signal to escape from the right atria through to the left atria. And then it activates the left atria from Bachmann's bundle. And notice the Bachmann's bundle is on kind of the septal region between the atria. And so the left atria actually depolarizes in a little bit of a different direction, right? This is happening almost simultaneously, but it's a little bit after the right atria. So notice the vector of depolarization for that P wave is going in a little bit of a different direction. It's going away from V1. So we actually get a little bit of a negative deflection for that P wave. And so this is what we would call a biphasic P wave. So that's the cool thing, is that we get a biphasic P wave typically in V1. It's not always perfectly exactly biphasic, meaning it's not exactly equal all the time, but you often see a little bit of positive and a little bit of negative forces in V1. And then the rest of our V leads, V2, 3, V4, V5, the signal's not necessarily going towards or away from these, but generally they all have somewhat of a little bit of a positive P wave. Sometimes you can't even barely notice the P waves that are being generated in these leads. It's really not a morphology of a P wave that we really care so much about. It doesn't tell us much about the beat of the heart, right? We want to get information that is relevant. V1 for our P wave and the precordial leads is really what we look at. The next thing that happens, right, is that signal gets captured by my AV node, right? Here's my AV node. And the AV node is what captures that signal and sends it down to the ventricles, right? So it sends it down to the ventricles, and so it goes down the bundle of His, it goes down my right bundle, and it goes down my left bundle. And this is happening at the same time, but I want you to notice that we've got these little projections off of the left bundle. And so the left bundle actually supplies the fibers that control septal depolarization, right? And so the first part of ventricular depolarization is depolarization of the septum, the interventricular septum, because that's the first signal that gets down to the ventricles, right? It's proximal to the AV node, it's right there. And so what's interesting about septal depolarization, if you notice, my left bundle is on the left side of my septum. And so that wave of septal depolarization, where is it headed? It's going from the left side to the right side, right? Because it's got to have a nice wave of depolarization that's going to go from the left bundle across the septum. And so our septum is small, so we don't think we're going to have a massive waveform on our ECG. But look at the direction of septal depolarization. It's going towards where? It's going towards V1. And because it's not that much muscle that's doing it, we'll see just a little hint of an uptick at the start of our QRS. That is called my septal R wave. And that septal R wave is just that little first sharp deflection that is because of the left bundle depolarizing the septum from left to right. In V2, you will also see a little bit of a septal R wave, but maybe a little bit bigger. Okay? So that's what we'll see in the septum. And you might see, notice that the septal R wave is going away, a little bit away from V6, so you might actually see a little bit of a small negative deflection in V6, not always. Okay? So that's septal depolarization. After the septum depolarizes, these signals are going to travel through our His-Purkinje system rapidly and depolarize the rest of the ventricles. Now, something I want you to remember is that the left ventricle is larger than the right ventricle, right? That makes sense. Our left ventricle is pumping blood to our entire body throughout the entire periphery. The right ventricle is pumping blood to the lungs, which are pretty close, and that's a low pressure system. So because of that, the left ventricle has a lot more muscle. It's thicker. And so whenever we get the rest of ventricular depolarization, we'll notice that because our left ventricle is a little bit stronger, we're going to have more forces that are going to be picked up that are going to be towards the left ventricle. And so when we get a wave of ventricular depolarization, the direction of that wave is going to favor the LV. It's going to be kind of generally more forces going that way versus we got a little bit of forces going this way, relatively speaking, right? And so as you could imagine, with more forces going towards the left ventricle, notice that those forces are going away from what? They're going away from V1. And so that causes the rest of my QRS complex in V1 to typically be negative, right? In V2, they're going to be a little bit less negative, but they're still going to be negative. But as we get to leads V3 and V4, we're starting to get closer to recognizing these left ventricular kind of producing signals. And so V3 and V4 is what we would call the R wave transition point. And somewhere between V3 and V4, what we'll notice is that the R wave is going to start to grow larger than the rest of the negative waves, right? So notice here that my R wave, which is R waves are positive waves. Remember that R waves here are starting to grow taller in V3, V4. And so this is what we're seeing is our R wave transition because those positive forces are being received and detected as we're moving closer in this direction, right? Because left ventricular is very thick. And so V5, V6, we're going to see big R waves, right? We're going to have very positive QRS complexes, right? So we call that R wave transition, where we see this small septal R wave that is here in V1 as we transition through V2, V3, V4, V5, V6. The R wave grows, and we call that R wave transition, and that's normal behavior. So let's review that. We've got a septal R wave here in V1 because the septal fibers are originating from the left bundle, which depolarize from left to right along our small little septum, and so we get small septal R waves in V1. And then those R waves will grow as we move from V2 to V3 to V4 to V5 to V6 as we're starting to capture more of those left ventricular signals, right? And so that's how we get the QRS morphology that we get in V1 through V6. And then our T wave, which represents ventricular repolarization, usually the T wave axis usually is in the same direction as the QRS axis. So because our QRS is predominantly negative in V1, you'll often see a little negative T wave. In V2, you might see a little negative T wave. It could be a little positive, it could be a little negative, but usually in V3, V4, you'll start to see positive T waves that represent ventricular repolarization. Okay? So that is our morphology of our precordial leads. So let's recap just a few things here. Remember that our devices, our ECG device, creates a lead with a negative and a positive electrode. All of the stickers that are placed on the anterior chest wall, V1 through V6, are the positive electrodes, right? And so then if we slice this gentleman through the midline, or not through the midline, but if we slice him transversely, kind of take a hack, horizontally, this is the view we're going to get. And so we see our V leads are all, created by positive leads that are the positive electrodes, and then we have this negative electrode that the ECG computer actually can create itself. And so we get because of the way that the atria depolarizes, where we get the right atria depolarizing first, and then Bachmann's bundle over to the left atria, we get this biphasic P wave in V1. The rest of the P waves are kind of not so important in the sense of the morphology itself. And then we get our characteristic R wave transition progression in our V1 through V6 progression based on the strength and the draw of QRS signal to the left ventricle. So I hope this helps you understand these leads better. If you have questions about them, please feel free to comment below. And I hope you enjoy this, and I hope that this helps you understand when these start to change, when the morphology that we are discussing here that is normal starts to change, you can understand where along the anatomical kind of landmarks of these electrophysiological structures the problem exists. So I hope this helps, and have a great day. See you on the next ECG video.